Thank you all for joining us this evening. It is great to see such strong engagement in this important and involving area of practice. Tonight, we will be exploring how physiotherapy can contribute to shift towards prevention, early intervention, and empowering patients to take an active role in their own health. We'll hear perspectives from community rehab, hospital-based care, frailty services, and oncology. Just a bit of housekeeping before we begin. Each presenter will be around 15 minutes, followed by approximately 3 minutes of Q&As. Please feel free to add your question in the Q&A section and not the chat. You also have an option to upvote the question you like, and we will prioritize and ask the most upvoted question. This session will be recorded for those who are unable to attend. And if you have any technical issues, try rejoining the session or check your connection. We encourage participation, so please feel free to use the Q&A section and chat section. Without any further delay, let's get started. So our first speaker is Gagan Singh Bhogal and Rebecca Copeland, therapy managers for Intensive Rehab Service, also known as IRS. With a combined of 26 years of experience in NHS, they bring a wealth of expertise in delivering proactive, community-based care. The Intensive Rehab Service was established in 2014 and operates using a virtual ward model, delivering care to adults within the community. The service supports 3 London boroughs and provides daily rehabilitation input for up to 21 days. Importantly, the alternate to this service would be often a hospital inpatient stay, either within the acute care or an inpatient rehab unit. So making their work a key example of proactive admission avoidance care, we're really looking forward to hear their insight. Over to you, Gagan and Rebecca.
Good evening, everyone. Nice to see you all. So if we head on to the next slide, and thank you very much for that introduction to who we are in our service. So we'll crack straight on into it then. So what does proactive care mean to us? So this for us really is about acting early rather than reacting late. It's about identifying those people who are at risk prior to their crisis actually occurring, and then working in an anticipatory way with a strong focus on function to maintain independence and avoid what is avoidable. So avoid them going into hospital, avoid that deterioration. So if we move to the next slide, please. So a little bit more in-depth information about our service. As you heard, it is quite a big service. We do cover 3 London boroughs. In order to do that, we have 54 substantive staff, which goes up in the winter to 73 substantive or 73 staff, which we include some locums or some bank workers. The staff within the service are a mixture of OTs, physios, rehab assistants, occupational therapy assistants, admin and nursing. We have at the moment an increased weighting towards band 7 and band 6 therapists, which we felt we needed in order to meet the complexity of the patients that we're seeing out in the community. All of our patients are offered up to 3 times a day input from therapy. So you might have an OT visiting, a physio visiting, and a rehab assistant visiting, or a mixture of all of those. We work very closely with our wider MDT as well as the MDT within the service. The wider MDT would mean people like GPs, crisis intervention services, district nurses, social workers, and all of the care is in the patient's normal environment, whether that's their own home or a nursing home, wherever they're actually residing in the community. We'll move on to the next slide. Some of the common things that we see for these patients that are coming through our doors, as it were, are infections. So things like a respiratory infection, urine infection, COVID-19, cardiac problems, cardiac deconditioning, post-surgical patients, and that could be surgery for anything that they've had within the acute, and all of the associated deconditioning from any of those conditions. Falls and any associated fractures, really commonly things like fractured neck of femur, fractured wrists, secondary conditions that come our way that aren't the main reason for the person being admitted to our service, but also are there in their past medical history, and neuro complications such as MS and Parkinson's, And we also sometimes have some amputees or some learning difficulty patients within our kind of remit. What it really means for us is that we need to be a bit of a jack of all trades within the service. As a physio, we need to be a little bit of an expert in everything, which makes it very interesting, but also sometimes very challenging. So if we move on again. So this is kind of our pathway of care and how we make this proactive I'll describe now. So our referrals come from a variety of different locations. They come from acute hospital sites. They come from our community inpatient rehab beds and other community services such as the GPs, the district nurses, our rapid response crisis team. Those ones that are coming from the community services, we would then step in and see them to prevent them being admitted into the acute hospital sites. And work in a proactive way to keep them at home. And those ones that are already in the hospitals, we're working proactively to get them out of the hospital as quickly as possible to set them back up at home to prevent any further deconditioning inside the hospitals. Our assessments are done in two ways, either over the phone or electronically via a clinical band 7 triage we've set up on purpose to be at that band 7 level so they can risk assess all of the patients that are coming out, and then they can signpost them onto our triage list and onto our caseload. So that way we can ensure that the patients who are most at risk are seen the quickest. The team complete then holistic multifactorial assessments when they go out to see the patients. And these assessments can include our normal therapy assessment, so your standard physio assessment, a falls risk assessment. We do screening for deconditioning, so we do a news assessment, skin assessment, and then from all of those assessments, we would design a tailored treatment plan around all of our problems, and then we would do some goal setting with the patient based on those. And then we would go out, and if the patient can tolerate it, as I said, we can go out for those 3 visits a day. Some patients don't tolerate that, and it's 1 visit, but it's very much tailored to them. So we'll go to the next slide, please. So why does this mean it's proactive? So what we're doing is a really early functional assessment. We're not waiting for them to deteriorate before we get in. If we identify a decline that's likely, we'll act and prevent the escalation. So for example, we might have a patient who's come out of hospital really deconditioned, they've not had any previous falls. We go in, we do our assessment, we find out actually this person's really at risk of falls, for it could be any manner of things. Maybe the environment isn't a good environment for them, there's lots of falls risk factors within that environment. We would then at that time immediately change the environment to make sure it was safe, decrease that risk of the fall, make the carers, the next of kin, the patient aware of all of the risks, and that's how we would then prevent them having that fall and any other complications around that. We're also making sure that we're preventing decline, we're preventing any escalations for our patients. We can talk a little bit more in detail about that on the next slide. So some of the sort of things that we do with our patients are sort of therapy-led interventions, which we've talked about. So our daily physio, OT, RA sessions. We've got some pictures on the next slide, and Gagan will talk in a little bit more detail around that. But we're looking at kind of exercises for strength, for range, for balance. We're looking at functional tasks and how we can work with our OT colleagues to improve things functionally. So it may be it's someone that's got poor balance, but the patient wants to be able to stand to make a cup of tea. So we might be saying, okay, what do you need to do from a physio perspective to be able to stand to make that cup of tea? Then the OT can then take when we say, okay, their balance is good enough now to stand holding onto a surface, the OT can then start working on their part, or we might do it together in a joint session. We do things like meal preparation, car transfers, stairs, and normal transfer practice as well. And another thing that we do is something we call an in-reach into the acute hospital. So this is another kind of arm of IRS that kind of links to that proactive care. This happens more in the winter periods, when the acute hospitals are under a lot more pressure. So the IRS would work really closely with our colleagues in the acute. We have staff members from our team going into the acute sites, and what they're doing when they're there is they join the whiteboard meetings, they're meeting up with the therapist, and they're looking to pull patients out of the hospital sooner into our service. We try not to have a waiting list during this time. So if someone comes out of the hospital that's been identified by IRS, we can then pull them straight into our care at home so they can have the rehab that they need without having to wait in the hospital for it. It just means that people are earlier identified, which is a really positive thing for them. We've got lots of good feedback from all sectors on that. So yeah, if we move on now, I think Gagan will talk a little bit more around kind of the types of rehab and some about outcomes.
Yeah, hello, nice to see you all this evening. So just a few pictures on the slides that show what we do out in the community. So you've got car transfers, you've got the meal prep and kitchen prep for patients, and then you've got your transfers on there. If we move on to the next slide. So what makes this work? So the model works because of its intensity and responsiveness. Therapists lead clinical decisions, and MDT work is embedded in our team. So we meet daily in the morning as an MDT to have a flash and look over our caseload for the day, discuss any complexities or plans going forward. And then we also meet once a week for our MDT, which is a bit longer. So we have flash meetings on the day, MDT once a week, discussing goals, progress with goals, outcome measures, which we'll move on to on the next slide. So the fast response enables us to act before risk turns into harm. So outcomes. So within IRS, so one of our key performance indicators or KPIs is having an improved TUG score, so a timed up and go score for our patients. So I'll just run through this because we've done a recent data dive for the 3 London boroughs that we cover. So approximately, so we saw so we meet our KPI of 80% of our caseload having an improved TUG score, which means they get quicker with the TUG. And then in the seconds wise, so we have an average of about 35% drop in the amount of time it takes them to complete a TUG. So if it took them 100 seconds, they were doing it in 65 seconds later. We consistently achieve these improvements in the outcome measure using the TUG. We also monitor a level of need, so that is care packages at home. So if somebody starts with a 4 times a day package of care, does it change towards the end of our intervention? And when we looked at our data, we could clearly see a reduction in packages of care and level of need in patients, which then translates into a monetary saving for the system. So we often use this data to have discussion with our commissioners to enable us to get winter funding later in the year. So it proves all good evidence. So the outcome measures having functional differences and also a monetary value attached to it to show our effectiveness. Next slide, please. Outcomes that matter. So with us being a daily intensive service, there wasn't much data out there in terms of our patients actually having sustained improvements over time. So that led us to do a qualitative basic data grab from patients. So we telephone interviewed our patients 6 months after we discharged them, just to monitor have they been readmitted to hospital. 76% of us patients in that group weren't admitted to hospital, which was positive for us to see. 74% said their mobility was back to baseline or close to this. The 74% also said that their quality of life was back to baseline and also maintaining their functional tasks. And 63% maintained their package of care or level of need after our intervention. So it's quite eye-opening to us because we always think, yes, we make a difference, but we don't know for how long that 3 weeks of intervention actually follows through in the long term. So it's quite rewarding and eye-opening for us that actually we do have quite sustained improvements with patients and they maintain function, avoid hospital admissions, and maintain their level of need in the community. Next slide, please. So over to challenges and learning. So we split this into 4 sections on here. One of the challenges is workforce and our workforce sustainability. So it's our key consideration, particularly maintaining skills, our capacity and flexibility needed for this daily high intense input. So within our team, we have a strong focus on training and development to enable staff to have the skills they need to deal with patients out in the community. So we are a rehab team. However, the type of patients we're seeing are quite subacute out of the hospitals, which means that they're either still recovering from illness, or actually by the time we turn up, they're going the other way. They're becoming worse in their health. So we do a lot of training around the deteriorating patient. We've embedded the new score and clinical obs within our initial assessments so that we have a base to monitor from. We also run bespoke learning sessions every 2 months on incidents. So it enables reflection, learning, because in the community things can be quite complex. Things are new to us in terms of the medical deterioration of patients, or something pops up. There's lots of MDT working that needs to be done in the community to help support a patient at home. We ensure this is well governed by having our monthly supervisions, note reviews, joint sessions with staff, so that we're learning from each other as well. The next thing was caseload intensity. So as Becky said, we have a band 7 running our clinical triage. So that helps protect our quality, safety of patients, helps us risk assess, prioritize those that need early intervention as opposed to our set up and safe at home and can wait a little bit for rehab, which we'll talk about the waiting list. In the past, we've had challenges with trusted assessments from the acute and risk management in the community, which is why it's important for us to have a clinical triage and a band 7 assessing these risk management. So in the community, we feel risk management is more complex than traditional models. It depends on clear clinical governance, clear escalation pathways, and confident staff to be able to identify and escalate concerns in a timely manner. And as you can imagine, we've got 3 London boroughs. There's three different processes. Sometimes there's 3 different referral paths. So it's really important that that we have clear clinical governance within our team to help identify risk and sorry, computer's about to go off there. Identify risk and escalate. We also work closely with our urgent care teams to ensure we can manage unwell patients in the community. And then finally, system integration. So this is probably the most important part. So this is ensuring there's a smooth link from acute to community, and this is going to be ongoing work. There's a lot of challenges around this. This is most people probably experience in NHS that one trust will use a different note system, the other trust uses a different note system. The information is difficult to marry up. So information sharing sometimes is a very difficult thing and a challenge that probably most teams in NHS come across. But we remain optimistic for the future that we can help gel the acute and community and work with our acute colleagues and get the right sort of patients out and smoothen out the referral process. Over the winter, so another thing that we didn't write on here because it's everywhere is money and funding. So we work quite closely with our commissioners to try and build a business plan on why rehab is important and why rehab matters. And I know the CSP got a thing about why rehab matters, and it does matter. We have we gather a lot of data on patient progress, function, readmissions to hospital, deaths, even for people that wait for rehab and deteriorate. That helps us basically get funding in the winter times, and hopefully more substantive funding so that we have the right workforce all year round. During our winter period of October till March, so we started that October period with an average of a 20-day wait for rehab, which in our eyes is far too long. We were set up initially in 2014 to respond within 48 hours. But over the winter period, with the additional staffing, with the in-reach, with risk management, we was able to drop that waiting list by 75% and get to majority of our patients within 4 or 5 days, which was excellent for us, excellent for the patients, and helps with outcomes. Becky will
sorry,
go on to the
Gagan,
next.
We've got 1 minute and we've still got.
That's all right. No, we've got 2 slides left. I told you we like talking. So.
No worries, we're enjoying it. Go on.
All right, so just to wrap things up then, and kind of our aims and our next steps, and linking really strongly back into this topic of proactive care. So there's some really exciting things kind of going on in the background that we're trying to get ourselves involved with. Some of the things we're more heavily involved with than others, but this is kind of where we see things going. So at the moment, there's some really early talks happening around pressure care that we're part of, which is looking at these kind of patients that sit in the acute, that haven't got pressure areas, they've had some kind of deconditioning, some kind of injury, they come home, they're very mobile in the acute, if they feel safe in that environment, they go home, they take to their beds to convalesce, and then they don't get back up until we go in. And as Gagan's described, if we are sitting with a bit of a waiting list, which we try not to have, but is inevitable for us at some points in the year, we might go in and find that that person who's just been sitting in bed for 2 weeks has now developed grade 3 pressure sores because of that sitting and waiting. And so we're looking at a project to try and prevent those pressure sores, looking at kind of how do we identify these patients from the acute, mark them as someone who's more at risk for that deterioration from convalescing. Do we need to do some education for patients, for their carers? How do we set that up? So that's kind of one bit of kind of proactive care around pressure. But there's also a really interesting project happening at the moment in Barking and Dagenham specifically that's using AI. So it will AI map a chunk of patients based on their risk factors. So it will look at things like polypharmacy, age, past medical history, and then it will say this person is most likely to have a crisis at some point in the next 6 months to a year, then signpost them onto a service that can support them from the community. So it's looking at preventing the admission before they get into crisis. So we've put our hands up and said, yep, we can be involved in that. We're well placed to do the rehab for some of these people who are highlighted as being at risk. GP referrals is another thing that we're heavily kind of pushing at the moment. So we're increasing the amount of our GP referrals that we receive, again, for these patients who are at risk at the community, starting to deteriorate, go to their GPs and say, oh, I'm feeling a bit off my feet. So we're looking at changing our referrals for them to make them electronic. So the GP presses a button and the referral goes. They don't have to call us and go through the rigmarole of phoning, which I know some of the colleagues on here will be all too aware about. So that's that, and there's a host of education series as well for the GPs around what we can do as physios to prevent some of these avoidable admissions. And very quickly, the last thing we're looking at is having some virtual exercise classes set up for our patients. So this is increasing the reach of our therapy. We're not taking over our face-to-face sessions, we're adding more sessions. So someone who is having 2 sessions face-to-face might top it up with a 3rd virtual. Someone with 3 face-to-face might top it up with a 4th virtual session. And what we're hoping is that from doing that, we'll improve the outcomes of the patient and improve that data that we've already talked about in terms of their rehab, really. And that is pretty much it. The last slide is just some key takeaway messages and any questions. Sorry if we ran over.
No worries. It was very insightful. And I especially like the idea about changing the environment, just start thinking ahead. And that's it. That's what you need. We don't have time for many questions, but I'm happy for to just have one question and answer discussed, and then maybe the other questions can be answered later whilst you all get your slides. So the first question which I can see is how joined up is the transition, what is the how is it to join up with the transition from hospital to community care and the handover received on discharge from hospital and the feedback to specialty teams on patient progress? So how are you communicating the patient progress within acute and community?
Do you want to answer, Gagan, or should I?
Here you go, Becky.
Okay. So because of our kind of clinical triage, what we have is we start off for most of our patients, unless they're community dwelling, and this is specifically asking from hospital, our hospital colleagues have an electronic form which they fill in, which has got our kind of key questions on it. They email that over to our kind of triage inbox. The triage inbox is manned every weekday for the core hours of the day. Our sevens would read that email. If everything on that email seems absolutely fine, they'll say, yep, this is fine, we'll accept it. We've done a lot of work with the acute trust that we kind of get our key referrals from the largest volume in terms of what information do we need and what's best for them as well. So what makes it quicker for them to send over to us and what are the key things we need to make sure the patients are safe in the community. We also have now got kind of virtual access to the electronic patient systems for our acute hospital trusts. There's 2 kind of main trusts that feed into us. And so if there are any things that we think, oh, we're not quite sure about that, if we can find it on their virtual system, great, we can now look that up from our triage perspective and see if there's anything. Or there's also the old-fashioned way, which I actually prefer, pick up the phone and speak to each other, get that clarification, have a chat with the therapist that's done the referral. So, I mean, in terms of how joined up, I think it's pretty joined up. We've kind of covered a lot of the bases from getting that information from the acute services with all of these different ways of receiving the information. In terms of feeding back to the speciality teams on the patient's progress, we predominantly just feed back to the GPs. We do closely work with people like the district nurses and the social workers. Again, we tend to use email, our electronic patient records and telephone calls to feed that information back. And it works really well. Yeah.
Wonderful. So in short, communication is the key. Just pick up the phone, email, and sort it.
I should have said that, shouldn't I? Much quicker. You're right. Communication is the key.
And thank you very much. Thank you both for your insightful talk. Very, very helpful. Without wasting any time and without feeling that it's just the physio community, we all know that wherever we work, consultants are the king, and consultants play a key role in shaping service development and driving change across systems. So how can we not have a consultant in our webinar today to come and share the insightful message for us, which again brings me to the next person who's speaking. Welcome, Dr. Alexander Sasha Harris. I'm so sorry because I'm used to call him Dr. Harris. And he is our next speaker. He brings his extensive experience to this space with over 27 publications contributing to the field of upper GI and cancer. We are very pleased to have him here with us this evening. Over to you, Dr. Harris.
Thank you very much, Harjit, for that warm welcome and inviting me to speak this evening. I'm really honoured to be here. What I'd like to do is share my experience of prehabilitation in upper GI cancer surgery throughout the course of my career. For the last 4 years, it's been based here in Essex, working with Harjit and her prehab team. But prior to that, I was based at Imperial in Northwest London, where I still have academic ties, and I wanted to acknowledge my friend and mentor, Krishnamurthy, who really introduced me to prehabilitation and what it can do for our patients. I'm going to spend the next 10 minutes or so just leading us through the problem, which is in the clinical context, upper GI cancer in terms of our patient population, looking at the disease process itself and the treatment options that we offer, and then some of the solutions to that and how they've evolved from our historical practice to the modern day evidence-based prehabilitation that's embedded in our practice now. Emilia, if I could ask you to kindly move the slides forward, please. Thank you. So upper GI cancers are not as common as things like lung, breast, colorectal and prostate, where many of us have friends and family who are unfortunately affected by it. But it's still a common problem. We have a National Esophagogastric Cancer Audit that every so often produces really helpful public infographics like you can see on the screen now. And it demonstrated that at least 20,000 people were diagnosed with upper GI cancers between January of 2022 and December of 23. You'll see from the top third that the vast majority were in their 70s, quite a comorbid population, often less active than they once were. They're coming to us 21% of the time as an emergency and up to 40% of the time with stage 4 disease, which is the most advanced stage of cancer you can get. Unfortunately, only 1 in 5 seem to be eligible for curative treatment, which involves surgery. And of those, only half might be actually fit to receive it. You can see from the surgical outcome data below that survival at 1 year is in and around 85%, both for cancers of the esophagus, but also of the stomach. Therefore, the vast majority of our patients are going to go for non-curative treatment, hopefully some form of palliative, either radio or chemotherapy, but they still need to be fit to receive that form of systemic treatment. And again, outcomes for that are poor, with approximately 1 in 20 dying within 30 days of starting that treatment. Next slide, please. So what this timeline represents is our current pathway. And just like Becky and Gagan mentioned about community involvement, we're working really hard for earlier diagnosis. There are charities set up and public engagement events to try and bring people's attention to difficulty swallowing, acid reflux that's not getting better, so that we can maybe bring in point of care tests to pick up patients who might have this condition sooner. But as I explained on the first slide, most of these patients are coming as an emergency or with late stage disease. And so it's really important that we make good decisions in our multidisciplinary team. And the vast majority of the time, that's based around what they're fit to receive. The second part of this slide demonstrates that surgery tends to be sandwiched between some form of neoadjuvant and adjuvant chemotherapy. And once again, that's a poison that we're asking an older comorbid population to cope with, as well as the hit from their surgery. Next slide, please. So in terms of patient factors, we're getting better at risk stratifying their frailty. You'll be familiar with things like performance status and ASA grades, but just looking at the past 2-year history of the patient, how many times they've been in hospital and what brought them in, enables us to work out who represents a higher risk in and around the time of treatment. This groundbreaking paper basically said frail patients do worse, and you can imagine why. But that's looking at things like not only their length of stay, but also readmission rates, things that we were talking about with the community groups, as well as mortality rates. Next slide, please. So those that are fit for potential treatments, this might involve historically chemoradiotherapy. Then a few years back, we developed a chemotherapy regime called FLOT, which is an absolute game changer, but incredibly toxic to the patient that receives it. And more recently, things like immunotherapy, that is still an evolving field, and we're getting to learn more and more about it. But as this paper demonstrated, those that undergo neoadjuvant treatment get deconditioned. Next slide, please. So, sorry, this should have come with a health warning. This is a pictorial slide of what's involved with an esophagectomy. These are 10 of the major steps that we go through. And you can see historically, this was a massive abdominal cut, giving us access to the stomach that we formed into a tube that we would then open the chest to bring up and make a join to the native esophagus, whilst clearing all the lymphatic tissue and diseased esophagus en bloc. As you can imagine, this is painful. It requires a long recovery. A chest infection is almost guaranteed, and you have to be super fit to be eligible to receive it, with what historically we told the patient would take up to 1 year to recover, even if they didn't recover back to their baseline function. Next slide, please. So, how did we determine historically who was fit for this? We invited them up after an endoscopy and a CT scan to inform them of their diagnosis. While speaking with them, we take a social history to work out what they were independent at, who they lived with, what they could do in terms of around the house, but also leaving the house. And we might do that by walking the patient either around the clinic or even up and down stairs. But the upshot was that we'd ask them to walk further and smoke less. Post-operatively, we were aware of things like analgesia and the importance of early physiotherapy, but a focus tended to be on rehabilitating the patient afterwards, rather than necessarily thinking of the 1% we could do better pre-operatively. Next slide, please. So during my time at Imperial as a postgraduate training in upper GI cancer, these ideas formulated into something called the Prepare Programme that Mr. Murthy and Venetia set up. This quite nicely fit into increasing their physical activity, giving them respiratory exercises both pre and post-operatively. You'd often find us after an operation ringing up a bit of a Blue Peter incentive spirometer, just with a bottle of saline and some oxygen tubing, so the patient would have something at their bedside that they could blow bubbles into and practice whilst they're doing nothing for the first 5 days post-op. We looked at getting them to eat well and had dietitians embedded in our service. We looked at their psychological well-being. We rationalized their medications and looked at the formulations so that patients that had difficulty swallowing could still receive the medications they required. We tried to stop their bad habits, including smoking, and we started to think about enhancing their recovery, and I'll show you a slide relating to that later. Next slide, please. More recently, there have been technological advances. So you might recognize the Da Vinci Xi robot on the left of this. And before starting my consultant role here in Essex, I went to visit Amsterdam UMC, who are the highest output of upper GI cancer work in Europe, and routinely do a laparoscopic abdomen and robotic chest. And you can quite imagine smaller scars being less painful, meaning that the patient can breathe better, go home quicker, and return to physical activity earlier. So looking at setups elsewhere really helped to inform me of what I'd like to bring into my consultant practice here at BHR. Next slide, please. So I mentioned enhanced recovery, and if you look at the top three things here, it relates to their pain relief, earlier physiotherapy, and nutrition. And that is something we took from the old days, but have tried to formulate into something that could be nurse-led. Increasingly, we're working cross-site with an elective hub after COVID, where we get guaranteed ITU beds. We have elective teams looking after patients, and we're not restricted by the impact of corridor care and the emergency services that we have here at Queen's. So it's really something that patients can fly through as long as they don't need to deviate from that protocol. And of course, there's consultant input 24/7 and doctors on duty 24/7 on site, even if I'm covering by phone. Next slide, please. So what we found at Imperial, by using the PREPARE programme against controls, both in matched and unmatched groups in terms of the demographic, admittedly small numbers, but consistently, they were getting fewer chest complications, and in particular, fewer pneumonias. And if you move on to the next slide, what we found locally was actually reflected in the wider literature with a systematic review and meta-analysis published just a couple of years ago. So there was an evidence base for what we were doing locally, but it seems to reflect practice elsewhere, even though we're not particularly joined up in upper GI cancer surgery in terms of our pathways. Next slide, please. In terms of how this works, again, these are postulated mechanisms, but it makes sense that if you improve a patient's function in terms of their physical activity and you get them complying with things like exercise, they're going to be physically fitter, physically stronger when it comes to the insult of surgery and or chemotherapy. And that physiological improvement improves things like sarcopenia, their lung function, and even down at cellular level, things that might impact inflammatory change. That might be interleukins, that might be TNF-alphas, but all of those demonstrate a drive towards a positive patient outcome through the things that we're doing preoperatively, while still giving them some form of treatment in advance of their operation. Next slide, please. So having shown you the evidence for this, how do we embed that in practice? Well, the North East London Cancer Alliance set up a pilot study when I joined 4 years ago. Harjit was an important member of that team at that time, and her data, along with Rory from our dietetics service, gave rise to something now is embedded throughout our patient pathways. In fact, no longer just with 4 cancer care groups in upper GI, lower GI, lung and haematology, but now moving into even our benign practice, where we've got a comorbid aging population who still have, complex gallbladders and other things that need to be addressed. They need to be addressed holistically with a multidisciplinary input. And what we've demonstrated is by offering that, we're improving the outcomes that we achieve. So what we hope to do moving forwards is to not just consolidate what we're doing, but move it forward with joint clinics between the prehabilitation team, the surgical team, and the oncologists. We've got a significant palliative burden in upper GI cancer, but we want patients to be fit to be able to receive that sort of toxic treatment. We're looking at digitalization because even though our patients are in their 70s, we're finding that they do engage with apps. Most of those are commercial, but we're hoping that we can do this through the NHS and the existing oncological apps that we've got. We've recently had some funding in the colorectal service for wearable tech so that we can monitor these patients quite closely in the community rather than waiting for them to contact us. We're doing 246 theatre planning meetings where we get regular updates from the prehabilitation team on our patient progress, and that's our way of ensuring that there's smooth delivery of care, whilst also considering metrics such as patient outcome measures, not just who goes through the programme and completes it, but also in terms of their quality of life afterwards. And as you're aware, there are other units that might be slightly further ahead of us, such as Imperial with the Prepare programme and Southampton, who recently presented at Algis, that we might be able to learn from and collaborate with in terms of learning what we can do better. For me, given our patient population, what I really want to learn about prehab is whether we can make more of our borderline patients operable by helping them in the preoperative phase. So that's a whirlwind tour of prehabilitation and its development in upper GI cancer over the past 20 years of my practice. I'll be very happy to take any questions and comments from the floor. Thank you for your kind invite and attention.
Thank you so much, Dr. Harris. It was really insightful. And yes, you are a very major big role in terms of helping prehab and setting it up. Just sticking to the time, we are just a few minutes over time, but we still can have one question. And then we can go on to our next speaker, which sits quite well in terms of corridor care, and our next speaker would be speaking about that. But before we go to the next speaker, you have one question, Dr. Harris. It is, how is the cancer prehab physio set up? Is it inpatient clinic or is there community outreach too? Well,
Harjit, you might be better for answering that, because there's a mix of both, isn't there?
Yes. So again, Sam, answering this question, I would say it is inpatient setting, but if you want to extend it in the community, you need to know what the main commissioners and key stakeholders want. So if your consultants and GPs are happy for their patients to get prehab before their treatment, then yes, you can set it anywhere.
Thank
All
you.
right.
Thank you for all of the work that you do.
Thank you so much. Thank you for your time. And thank you for your insightful talk. Our next speaker is someone who does links quite rightly with the talk or with the expressions that Dr. Harris has given us. So I do welcome Liz Chesterman, our clinical specialist physiotherapist who works in Barking-Havering and Redbridge University Hospital. Liz's work focuses on reducing avoidable admissions for frailer older adults at the front door. She has also been involved in a number of front door initiatives aimed at improving care for older people attending the emergency department. We welcome you, Liz, and looking forward to hear your perspective on physio proactive care. Over to you.
Thank you very much. And thank you for the other two speakers. It's been lovely. So, and welcome everyone. So, so like Harjit said, I've been working in the NHS now for about 15 years and naturally seen the shift. If we go on to the next slide, we've seen a shift really in the NHS from that reactive care to proactive care, especially at the front door because of having to support emergency care performance. I myself have got a real passion for improving care for older people, but also a big advocate for promoting our role as physiotherapists. And working at Queen's Hospital in Romford, we have tried to work very hard to find the right balance of proactive physiotherapy, and it's still a work in progress, but I hope the presentation will start to touch on bits and pieces and help support those who might have similar passions. Next slide, please. So Queen's Hospital is an incredibly busy emergency department with some of the highest attendance rates in London. Queen's Hospital was designed for about 300 people attending every day to the emergency department, but it currently experiences over 600 a day. We serve 3 London boroughs, and one of those is Havering, which has the largest proportion of older people in London. It's about 23% over the age of 60, compared to the London average of about 16%. We've done lots of data collection over the years, and we found that on average, older people are spending about 33 hours in the emergency department waiting for a bed in the hospital. And of course, like was mentioned by Harjeet there about corridor care, and we would have all seen that on the news, but also that's a huge risk of deconditioning at older adults, and we wanted to look at a way of helping to prevent that. Next slide, please. So deconditioning, I'm sure most of you have heard about NPJ paralysis and those movements and deconditioning in hospital, but it can actually start within hours of a patient lying on a trolley or a bed. And up to 65% of older patients do experience a decline in function during hospitalisation. Recently, the Royal College of Physicians have put together some awareness about frailty and deconditioning in the acute medical units and acute medical take, and sort of reiterating that it is everyone's job. But as physios, obviously, we take a key role in this. And one of the key things to sort of focus on there is that key figure of 83% of an older person's time in hospital is spent in bed. So if we can do something from physio to prevent that or get them out of hospital, that's what we should be working towards. Next slide, please. So why did we want to start taking a proactive approach? So first of all, we wanted to better use our physio skills. Too often, I think we're used as discharge facilitators in the acute trusts, and just check mobility before discharge. But actually, we have a much bigger skill set than this, and we're severely underutilised in the acute hospitals because of the pressures we're under to get people out. We can use our physiotherapy skills to support doctors in decision making, identifying possible spinal injuries, musculoskeletal injuries, neurological conditions, and assessing falls. That's a huge opportunity for us to really delve into our physio skills, vestibular assessments, balance assessments. We were really tired of seeing OTPT at the end of every plan, and I'm not saying that's changed, it still happens, but we wanted to do something about it, because OTPT, it's just a phrase that we don't want to see. And many people are referred to physiotherapy just because they're old. And I say that with inverted commas. Just because someone's 90 doesn't mean they need to see a physio before they're allowed to get up and mobilise to the toilet. That 90-year-old might also be going to the gym 3 times a week and is fitter than I am. Also, we wanted to prevent a delay in referral to physio. I'm sure those who work in inpatient areas have had experience when just before the patient's meant to be discharged, having been told the patient's bed care for the whole of the admission, the day before they're going home or the day of discharge, told, actually, you know what, Mrs. Jones normally walked with a frame and had carers once a day. And suddenly, as a physio, you're trying to undo potentially several days of deconditioning. And it's really hard. We then send people home a lot more dependent than when they first came in. So that's what we were working towards with our proactive approach. Next slide, please. Not only from a physio side of things, but from a care of older people. Some of you should be aware of the comprehensive geriatric assessment, and this is a term that's used to describe a structured multidisciplinary approach that improves the care for our older adults. It's evidence-based, and it's got a lot of recognition for its role in improving care of our older frail patients. So as physios, we can get involved with the comprehensive geriatric assessment because it is holistic. We're looking at the functional, the physical side of things, also the social and environmental. And there's a huge amount of evidence that if this is being done in acute settings, including the emergency department, it can lead to reduction in inpatient falls, reductions of admissions to long-term care following a hospital admission, so care home placements, reduction in hospital-acquired delirium, admissions rates from the emergency department into the hospital, reduce functional impairment, and also prevent readmissions to emergency care. Next slide, please. And just some more evidence. So significantly more older patients are likely to survive admission to hospital if they undergo a comprehensive geriatric assessment. So us being part of that can improve the mortality for our patients. It also encourages role blurring. So as physios, we start to do a little bit of OT work, still working within our scope of practice, but improving the care for our patients. And working at front door in a multidisciplinary frailty service, we're looking at improving discharges and getting quicker discharges, so getting people back to their own homes, but also this holistic assessment to prevent readmissions and keeping people as independent as possible for as long as possible. Next slide, please. So our journey has been going on a little while to get to this process, and it started before COVID. And of course, just like Gagan mentioned in his presentation, a lot of it is to do with funding and having to demonstrate our value as physiotherapists. So initially we started with a really small pilot, which eventually then turned into a business case and became permanent. And we placed one senior physiotherapist and a therapy assistant in the emergency department. And we were initially reviewing patients who were going to be waiting in ED for a bed in the hospital. So those patients that had been identified as potentially needing to come in for a day or two for some IV antibiotics, repeat bloods, actually, can we start them a bit earlier and prevent deconditioning? Can we start to get a discharge plan together? Then between 2021 and 2023, there was a development of a new frailty unit alongside our geriatricians, and we started to screen all patients who were attending the frailty unit, including those direct from ambulances, to determine if therapy is indicated and start therapy intervention sooner, but also help with the comprehensive geriatric assessment. And from 2023 to now, we've now got a team of 3 physios, 2 therapy assistants and 1 OT working in the emergency department. We still work alongside our geriatricians in our emergency department to identify those who require intervention and commence as soon as possible. And we are even screening at the point of attendance to ED from the ambulance. Next slide, please. So how do we do that? So what we do is we proactively screen our emergency department list for any patients over the age of 75 or a CFS above 5. So for those who aren't aware, that's the clinical frailty score, and it's an indicator of an individual's frailty, and we can look at preventing moving into frailty. So what we do then is commence a screen, and again, or a therapy initial assessment to determine if a patient requires therapy. And when I say screen, we're looking at the sort of a reason for admission. Have they come in with falls, reduced mobility, unsteadiness? Those that are definitely going to need us, we're likely to get involved with and commence therapy. But there might be other reasons why a patient's been admitted, but we can reduce the need for physio intervention later down the line. So someone that's maybe come in generally unwell with an infection, actually, if we know Mrs. X normally walks with a stick, let's encourage the nurses to get her up and use the stick. So what we would do is we would start to commence intervention as soon as possible, and this could be as simple as sitting out of bed in the emergency department. But previously, these patients wouldn't have done that. They would have sat in a bed or a trolley for at least 24 hours. And we might even be able to discharge directly from the emergency department. But if they can't, then we would at least start the discharge planning, and we would link in with some of our community partners. If they don't require physiotherapy, then we would signpost to appropriate community services. So we would signpost people to Age UK exercise classes. We could refer them to falls prevention classes. They might not necessarily come in with a fall, but we want to prevent them. So trying to catch them earlier before they get to the point of coming into hospital. Next slide, please. That's just an example of one of our screens that we used to use. So it's just a tick box, very simple. And this would be on a different colour piece of paper that used to be in the medical notes. So at a quick glance, a nurse or a doctor could pick that up and have a little look at what is normal for the patient. Unfortunately, we've now onto an electronic system. So we're working on how we can start to have something that's similar in the electronic system. Next slide, please. So just some more about what we do. So I think one of the most exciting things is working alongside our ED senior doctors during ambulance handovers. We've done various little pilots, and we found that we can really try and capture about 82% of patients coming in within 30 minutes of arrival. We can start to get their social history and start to figure out whether they're going to need therapy. And we keep an eye on the ambulance screen to see who's coming in. So we know, oh, look, there's an 87-year-old person that's coming in with a fall. Let's get there. Let's get started and see what's happening. That can also help with decision making from the MDT, often because patients are, old and seem to need OTPT. Actually, we can turn around and say, you know what, they were managing absolutely fine. They don't need to see us. You guys keep them mobile. Let's get them home as soon as possible. But also we might help reduce unnecessary investigations. For example, a patient who's mobilising around the ward with, have come off the ambulance, has walked to the bed. Do we really need to do a hip X-ray if they're actually already walking? Probably not. And also we might be picking up things that the doctors might not have picked up because we're using our physio skills. And then we'd link in with our specialist frailty nurses and geriatricians to support moving patients to dedicated units like our frailty same day emergency care unit, or getting them home quicker with support from our community services. Just like Gagan and Rebecca's team, we would suggest they maybe go home with IRS and have their rehab at home rather than be in hospital. Next slide, please.
Just a reminder, you've got a few minutes left, Liz.
That's fine. So I'm not going to go into too much of this evidence and data, but really what I wanted to show is that 36% of patients that we see are discharged directly from ED. And regardless of whether a patient comes into, whether we've started them in ED and they move into the hospital because they're unwell, what we've shown is that we're saving 2 days length of stay for these patients that we start early as possible in the emergency department. We are seeing they are reducing their length of stay when they move into the hospital. Next slide, please. So just in conclusion, we can have reduced length, we can help influence reducing length of stay and less admissions into the hospital. Being proactive is better for patients, prevents deconditioning, less time spent in the hospital, less time spent on trolleys in the corridor, greater independence on discharge, better staff satisfaction, staff feel empowered to use their clinical reasoning skills, seeing the right patients, keeping patients independent, and overall improving emergency care performance. If you go to the next slide, please. So ending on a positive, I feel like we might have had a little bit of influence on this. I'm sure there's been some other things, but I like to take a little bit of credit for this as our team. And sort of last year we were looking at Queen's Hospital on the news, being footage of war zone and the corridors and having multiple patients in the corridors, to actually now in the last couple of weeks, actually we have no beds in the corridor, and this is being sustained despite having the same amount of patients attending. So hopefully being proactive as physios and getting some of our frail elderly patients up and about and out of hospital is the key. Thank you.
Thank you, Liz. Such a practical talk, such a practical talk. It is great work. You're getting some good comments. Thinking about and planning the discharge from the point of admission is vitally important and current climate. So, and yes, great work in reducing corridor care. 100% we've seen the impact. So thank you so much for your time. And
thank you.
I think there's no Q&A, but if there is any questions, feel free to put it in the Q&A box and we can come back to you with the slides. The answers will come back to you with the slides. So finally, we have joined the final section, and I would like to welcome Hannah, a breast clinical nurse specialist at Barts. Hannah is currently working as a CNS in oral SACT clinic. She treats both adjuvant and metastatic breast cancer patients. But unlike her job role, she'll be talking something about how proactive approach can change and help support patients to provide their care without being in the normal environment. So over to you, Hannah. I think you're still in mute, Hannah.
I'm not sure. I think Hannah might have dropped off. I don't know if she's having technical difficulties, but she went out and came back in, so she might just be rejoining.
Okay, we can give her a minute. If not, I can start speaking about 5K because I am also one of the ambassadors of 5K Your Way. But it would be nice if she can spread it out her way. So basically, this is like an approach where we've all have heard about park runs, but in park runs, there's a little stall. If you are a runner and if you go Saturday mornings for park runs, see that little stall, which signifies 5K Your Way. And yes, that exactly is the approach to kind of proactive care. So people, all the consultants and GPs, even physiotherapists in East London, we've started promoting and sending our patients for park run. Once they're there in the park run, then they just get used to this quality of life approach, and they are very, very happy to be a part of a group where the consultants are already there. Some of the pictures are shared by Hannah, I would say. Well, it's a very positive group and it's a very nice approach. But like the other talks are saying, unlike the normal physio approach, it is try and thinking ahead beyond, try and thinking how we can encourage our communities, how we can use things which are already existing around us to promote physiotherapy, to promote quality of life, and just catch things before they are already occurring. Have we got Hannah in the meeting room, or is she still?
I think she's joined. I just need to give her the ability to unmute. So give me one second.
Mm-hmm.
Hi, I was just having some internet with my laptop, so I'm now on my phone, which apparently is connecting. Can you hear me okay?
Yes, we can. So over to you, Hannah. Go on.
Hi. Thanks very much for allowing me to just talk about 5K Your Way. I'm a breast CNS and I work at Barts, and I was actually introduced to 5K Your Way by one of my breast cancer patients, who is an avid runner. She's actually has metastatic breast cancer, and yes, she brought me along and told me about the group that's linked to Barts, that we meet on the last Saturday of every month at Barking Park Run. And it's formulated of patients, NHS staff, local GPs, physios, some nurse specialists, but most importantly, patients. And it's a way of supporting each other, and supporting our patients. And there we have a poster that is advertised in clinic and outside the Cancer Information Centre at Barts. We also have links with our physio department, who because we have a breast prehab team at Barts, and they encourage our patients who are part of the breast prehab to attend. There's a QR code that I offer to every patient I see. I run an oral clinic, so a lot of my patients are quite deconditioned through their cancer treatment, and struggling with weight gain, menopause symptoms, and are looking for a way of getting back to their old self. And the 5K Your Way movement actually is exactly what it says. It's to do 5K or even less, whether you walk it, run it, jog it, or just come for the coffee after. So that's our poster, and on the next slide is just a few photos of us in action. And the last park run we did was actually at Valentine's Park Run in Ilford, and we linked up with the East London Cardiovascular Disease Prevention Team, who because they just got wind of our activity from our intranet advertising of the group, and now we are doing planning to do quarterly park runs, linking with the cardiac team, with involving a little bit of health promotion. So the next session in July, they're planning to bring a defib over, just to sort of demonstrate how to use a defib. We had good engagement with the cardiac patients that attended last week. So yeah, that's about basically all I need to say about 5K Your Way. So happy to have questions if anyone has any.
Any questions, or if you would want your patients, your clients, your family members, or even yourself to join, feel free. It is a very proactive approach and very positive group.
Mm-hmm. Absolutely.
So thank you very much, Hannah. And as we come to almost an end of today's session, I would still say don't just listen and leave the workshop, please, because we still have AGM coming. But before that, I'd like to extend a sincere thank you to all of our speakers, their time, their expertise, their excellent contribution for this evening. Each talk has highlighted how proactive approach can embed across different settings, from community rehab to acute settings, frailty, and finally in oncology as well, all working towards prevention, early intervention, and improved patient outcomes. Thank you all and everyone who attended this. Just a reminder that the slides and the responses to any unanswered questions will be shared with you after the session. We hope you found today's discussion helpful, inspiring, and thought-provoking. Thank you again for joining us, and we hope to see you again in our future events. Now, I will hand the chair to Chris, who can lead the AGM. So, Chris, over to you. Chris, you're still in mute, just in case you're speaking.
I think Chris is just having some technical difficulties. So if anyone wants to grab a drink or go to the loo or anything, come back in a couple of minutes and we'll hopefully get Chris back.
All right, we can have a look till that time at the Q&As. There are some highlights in there. About looking ahead at digital records in ED. Is the universal care plan gaining traction in your locality? I believe it's been rolled out pan-London and patients can initiate via their own NHS app and GP. Yes, I agree. And there's a lot of work going across, 100% I can say, across the North East London ICBs about NHS apps, electronic records. So that is something. Going digital and looking ahead in terms of AI and stuff is the future. So we all can be proactive. We all can put our heads in those meetings, keep our ears up. What are the talks going on in any team hurdles? And then just put ourselves out in that respected service development to see whether that means something for us. There was another question. All right. Do we have Liz in the panel or have Liz left? Amelia?
She might have left. I'm just checking. I think she's left, but we can, if there are any questions, we can get them answered after the event, if that's all right.
Yep, that would be good. I would also like to add on, there would be a feedback form following this session, this webinar. So if you have any topics that you feel that you would like to get more insight on, just please feel free to put it down and then we can plan our next session on that. Any questions, any queries, any learnings you feel that you need to bring, you want to get a little bit more insight what's happening, just please feel free. Sorry about the technical difficulties. Sorry, Amelia. Chris can't unmute himself, so he's trying to.
No worries. I'm just trying to figure that out.
We still have 3 minutes. So for people who don't know what is AGM and what is going to happen in the next 15 minutes, I can briefly give you an insight. So basically, the London Regional Network was formed. Oh, you're here to the rescue.
I don't know if you can see me at all. I can get my mic unmuted, but I just can't. Now the camera won't. It's not unmute, is it? But it won't show me.
No problems. We can hear you. So your voice
You
is
hear
more
me,
powerful than video.
As long as we can see you, that's the most important.
Yes. Go on. Over to you.
Perfect, great. Well, thanks for hanging around, guys, and thanks, Harjit. Wonderful webinar. It takes a lot of organising behind the scenes, so thank you very much. It was a great hour or so. My name is Chris Whittle. I'm currently the interim chair of the London Regional Network for the CSP. Welcome to the annual general meeting. We are doing this meeting in two parts, really. So just a brief meeting tonight from me to recap the year, give some information about the group and group members. And then the main goal really of the meeting tonight is to ask anybody who would like to come and help and is interested in being part of the network to put their hands up and come and get involved. I'll come on to that, and maybe Harjit can give some further information soon as well. So just to recap the year from last year, we had a really successful year building on from 2024. In 2024, the network won the National CSP Network of the Year, which we're all really proud of. After COVID, the network had a bit of a lull, and we all managed together to bring the network back up to speed and create a resource really for CSP London members. We've done a lot of work behind the scenes at ARC. So we presented 2 motions at ARC back in May, June of last year. One was asking the CSP to actively approach or actively engage with workplace burnout. That was passed by members, and there's work going on behind the scenes on that. And one was a more technical motion as part of the network to extend core members' membership over a 2-year period rather than a 1-year period, and that was passed also. A number of members have also developed personally. We've had members presenting at conferences. We've had members approaching and working with their local MPs. So there's a big wealth of skills that can be acquired as being part of a network. And Lawrence, I can see you there. Lawrence won the Student Influencer of the Year for 2025. So lots and lots going on behind the scenes, loads of really positive things and real sort of benefits that you can gain personally from being part of the network. We do have some outgoing members of the team. Camilla Gopping is leaving. Camilla was a core member and the previous chair of the group. Camilla chaired us to our national award back in 2024. Sam Preston is a core member who will also be leading the group. Sam presented the motion for an ARC on the technical membership, and Angela Webster was a core member and also took on the treasurer role, will be leaving. And I will be leaving also as interim chair. My previous role was vice chair for the group for the last 2 years, which takes us on to our new leadership team, which is really exciting sort of change happening, and also part of the reason why we wanted to hold this today. And then we'll hold a further meeting in a couple of weeks for prospective new members. So welcoming Harjit Maras, who is now the vice chair of the London Regional Network. Chairing the group will be Shu Jarchi. She can't be with us tonight. She's away, but we'll certainly look forward to your leadership and to see where you take the group. And that might be a nice time for you to come in, Harjit, and just give us a few words about where you may be taking the group and what you've gained really over the last few years.
Oh, I know it was wonderful, but I would say over the past 3 years, being a core member of London Regional Network has genuinely been rewarding. Again, both for me and professionally and personally. It has given me the opportunity to grow, develop new skills, most importantly, connect with incredible support and inspiring network. I've built on most value during this journey, and I am so grateful for that. Reflecting on what you said, Chris, yes, the network has achieved some significant milestones that we're incredibly proud of. We were recognized as the best network within the CSP, which reflects the dedication, collaborative spirit of the entire team. We were also successful for our burnout motion, which got passed, and it helped bringing much needed attention to workforce well-being at a wider level. I'm really pleased to share that now I've been selected for the vice chair role, and I am excited with the next step, looking forward to build on what I've learned so far. My aim is to extend these positive experience to CSP members across London and deliver best possible experience in this role. I also want to take a moment to acknowledge the team I've had and the privilege to work with. It's never easy to say goodbye. And I do so with a slightly heavy heart, but also with the hope and expectations that many of you who are leaving us will rejoin in the future as your work and your personal life allows. Your contribution have been invaluable, and this network is stronger because of you. Finally, I would really encourage new members to get joined. Come on, join us. This is a fantastic opportunity. There's so much to do in the future. We want to welcome fresh ideas and make this even bigger. So looking forward to see some of y'all's expression of interest to the network. And thank you so much, Chris, for allowing me to speak.
Well, pleasure. Thanks, Harjit. I am trying really hard to get my camera on because I don't really want to just do this without the camera, but I can't seem to make it work, unfortunately. The chat is open for any questions or anybody that would like to bring up any other business. They're on front of you on screen. Hopefully you can all now see how to find out more about the network and how to submit an expression of interest in joining the group. I would wholeheartedly encourage anybody that's thinking about joining the network or has an interest or to get involved. You know, Harjit summarised things really well there. There's so many benefits, and Lawrence is also a core member. Lawrence, I'm sure, hopefully you might agree with that, that there's a whole world of opportunities out there for collaboration, for networking across London, and I would wholeheartedly encourage people to join the network. If we don't have any questions, and if there is no other business, I presume then here we go. There's some feedback. There's a feedback form there where you can leave some feedback on the webinar. Our next official network webinar will be around clinical AI beyond documentation. That's on the 16th of May from 10 till 12. And within the next 2 to 3 weeks, a further meeting will take place for all those who have expressed an interest in joining the group to find out a bit more about the group, what we do, meet the wonderful Harjit and Shu, and Lawrence as well, who's the current member. And then only leave it for me to say, Harjit, I wish you all the very best success. Lawrence, you too as well. I'm sure everybody that has been involved in the network will support you fully. If you've got any questions or any problems at all, anybody come and have a chat. But I will be following and joining in any network sort of face-to-face meetings. You know, be very, very happy to stay involved. Well, thank you very much. That's the end of our AGM. I don't see any questions or any other business. I will sign out. Thank you very much.
Thank you, Chris. Thank you, everybody. And I would just say and encourage, keep tuned for our next webinar, which is AI Beyond Documentation. I'm sure everyone's using ChatGPT. Let's see what ChatGPT and AI means for our documentation. It will be very insightful and very exciting. And also, as you've seen, you can just attend the webinar. You can just attend it, put it on. Maybe you're cooking, maybe you're doing something else. Hear, listen, or maybe just go back to the recordings and see if there is anything useful for you. The feedback will follow you. And again, thank you everyone for your contributions, the chat box, and everything, whatever you've provided today. Hope you have a good night, and I will not keep you very, very long. I'll let you all sign off, and thanking everyone on behalf of London Regional team.